we're live. So I want to thank everybody for being here today. Like I said at the beginning of the presentation, we have people from Lebanon, we have people from Jordan, Oman, Bahrain, Egypt, Turkey. We have people from Saudi Arabia. We have a lot of people from all over the Middle East. So thank you for being here with us tonight. I hope that you had a good day today, and I hope you are enjoying your Ramadan. So today we're going to talk about very important aspects. So we're going to talk about two technologies that are not available in the Middle East right now. One of these technologies is ortho-K lenses. Ortho-K lenses are lenses that you wear at night. The patient wears them at night, and they remove the lenses during the day, and the patient has great vision during the day and with no need of contact lenses, surgery, or glasses, okay? So the ortho-K system in the United States is one of the most prescribed products right now. And both scleral lenses and ortho-K lenses are showing the biggest growth worldwide right now. So I'm going to tell you a personal story. When I was 9 years old, I was minus 175, okay? And I wish that I had this technology, because now that I'm 38 years old, I am a minus 4. So imagine if I was able to wear ortho-K lenses throughout my life. Maybe I would not be a minus 4. Maybe I would have remained with my minus 175 prescription. But at the same time, I could have go out. I could have ride bikes. I could have done a lot of things that I was not able to do so because I was wearing glasses. So my mom did not allow me to go out and play with my friends because I was minus 175 and I was wearing these thick glasses back in the 90s. So any type of sports, any type of cycling, any type of activities, I was prevented to do so because I was wearing glasses. So now patients can have the freedom to feel the wind in their faces, and at the same time, they're gonna have the freedom of not wearing any correction during the day, and we can practice myopia management on those patients using these two systems. So again, we're gonna talk about two systems today. One of the systems is ortho-K, which are lenses that you wear during the night and you take them off during the day. And then we're gonna talk about soft, custom silicone hydrogel lenses for myopia management. So the first speaker today will be Dr. Davila, and the second speaker will be Dr. Maria Verhoor from the Netherlands. Dr. Davila, the microphone is yours and the podium is completely yours. Please kill this presentation.
Thank you very much. I'm really happy to be here with all of you, sharing a little bit of information that we have. During this time, sometimes it is a little difficult to actually be studying and doing webinars, but it tells a lot about the responsibility that you have towards your patients. So we're really happy to be here. I just added to the group Amer Salame and Noor Abdu. I just added them to the myopia control group, or the LATAM group. So they actually are in already. So like Felipe said, we are going to discuss a little bit about Euclid Emerald. This is one of the platforms. It's one of the most used platforms all around the world. Actually, everything started in Asia with the Euclid platform. There are different interventions whenever we're doing or we're dealing with myopia control. And this is probably ortho-K is the best one of them. So we want to get some information regarding it, and we'll discuss how to do this. Like Felipe was saying, sometimes I started almost 15 years ago. It was my first K doing ortho-K. I was so amazed of how it worked that I have to call that company and just let them know that I had my first patient, that he was seeing 20/20, no glasses, no contact lenses. He was doing really, he was really happy and doing really well. So it was, I was amazed by this technology, and that was 15 years ago. Can you imagine? After 15 years, we have better platforms now. We have excellent results. We have now better platforms in order to actually share the information and to give webinars and to train people. So it is a really nice time in order to do myopia control, specifically with ortho-K. So Euclid is a 34-year-old company. It has a long-standing focus on improving the lives of patients with myopia. It provides more ortho-K lenses to ECPs, that's eye care providers, annually than any other company. It is the global leader in ortho-K lenses with nearly 2 billion lenses on eyes around the world. They have some of the most complete research about ortho-K has been done with this brand of lenses, the Euclid lenses. If you have read the SMART study, SMART study is actually the biggest study done in ortho-K. The SMART study was done with Euclid Emerald lenses. It is a pioneer in receiving government approvals for ortho-K. FDA, that's the federal agency that deals with contact lenses in the U.S. We have been approved since 2004, and recently in China, we say 2007, so almost 13 years ago. It was the first ortho-K lens approved in Japan and Taiwan, and this is the first U.S.-based company to have wholly owned Chinese subsidiary. Okay. The big question is, why are we so worried about myopia? Because, well, we have dealt with myopia for hundreds of years. The thing is that we have to start seeing myopia as more than a normal refractive condition. And I will be giving a little bit more information about why we have to see it as more than a refractive condition. The other thing is that the prevalence of myopia has nearly doubled since the 1970s. So it could be expected, normal myopia could be expected to become the leading cause of permanent blindness, and you'll see graphics about it. Based on historical prevalence data and future projections, there will be 5 billion people with myopia by 2050, or 50% of the world's populations. And the other thing that scares us is that out of those 5 billion, 1 billion will be high myopes. And you will see why high myopia is scary, okay? There's that in order to deal with that, actually, this is another pandemic. Myopia can be seen as a pandemic because it's all around the world. There's significant implications for planning comprehensive eye care services globally. The reason is, as you can see, in order to follow this, why are we so worried about myopia? High myopia significantly increases the risks of more serious ocular health, including, like I can show you over here, 7.8 times increase in retinal pathology, 3.3 times increase in cataracts, and 14.4 increase in glaucoma. That's why I was telling you that we have to start looking at myopia not only as this normal refractive error, but sometimes as a pathology that could create blindness all around the world. I work with a retina specialist here in my country, in Puerto Rico, and I have seen so many people here, young people, 30s, 40s, 50s, with retinal detachments. And if you analyze the data, the thing is they are high myopes. I remember years ago when we talk about high myopes, we talk about high myopes like people with -10 or -11 or -12. Now, with the newest definitions provided by the IMI, high myopes is anyone beyond 6 diopters. So I used to see 6 diopters myopes like a normal thing, but now, if it is high myopia, all these things may happen. And of course, pathology, retinal pathology, cataracts, and glaucoma are things that may cause blindness. That's why we're so worried about the myopia pandemic. In March 2015, there's a report done by Brian Holden, the BHVI, the Brian Holden Vision Institute, and they say that if they can reduce the rate of myopia progression by 50%, they could reduce the prevalence of high myopia by up to 90%. So even since the late Dr. Brian Holden started doing anything that has to deal with myopia control, he has been worried about what could happen to our future generations. Okay, we're talking about our kids, our teens, maybe also our grandkids later on. If this continues to happen, these trends continue, we're going to have a lot of problems. Okay, so what are the possible methods from proactively managing myopia? The research shows that we have been discussed almost 16 different interventions. But out of those 16, these four that we have here are the ones that have more clinical evidence that supports the specific intervention. I'm going to mention these four. The first one is orthokeratology, contact lenses, correction-free, clear daytime vision. The second one is multifocal soft contact lenses, and later on we're going to talk a little bit about that. The third is atropine. It could be used in different dosages. Of course, when we deal with atropine, that's some side effects like glare, photophobia, and near vision that we have to deal with that. In some countries, it is not available at all, and we have to take that into consideration if we're going to do atropine for our kids. And also outdoor time. We have, in order to prevent myopia at a early age, we have to provide our kids with more outdoor time. I remember years ago when we were kids, we used to play outside for hours without any problem, and everyone was happy and everyone was okay with it. Nowadays, you see the kids not practicing that many sports, just being inside playing, doing PlayStation, Xbox One, in the computers all the time. So all of these things may cause or may lead us to myopia progression. So the possible methods are here. Also, we can talk about the even in Asia we have, and so in some parts of Europe we have different ophthalmic lenses that are created in order to deal with myopia. But if you ask me, what will be one of the safest and most effective methods will be ortho-K, and there is a lot of studies and research done about it. Okay. Why ortho-K? Well, ortho-K offers some really nice different advantages, right? First, it's a device free during the day, so you don't have to use anything during the day. Remember, these lenses are worn at night when the patient is sleeping, and this is especially beneficial for school age or children. During the day, they don't have to wear anything. So during the night, you can actually see what they're actually doing, verify that everything is okay. You don't have to worry that they don't use their eyeglasses at school because there's some bullying with it, things like that. Also, there's some convenience of overnight only wear. Remember, it provides home-based parental supervision. So you can, at that time, usually kids are within their homes, and of course, you will actually be seeing them. There's minimal adaptation symptoms if you compare to other different interventions. Remember, the patient will be actually sleeping. And then, even if the patients have a little bit of dry eyes, you can actually wear this type of lenses. I mean, if the patient has maybe a mild dry eye condition. Severe is a whole different story, but we can deal with that later on, okay? Also, the outcomes will be really predictable if we do a good or a proper patient selection. And the thing is, if after using ortho-K, you want to stop it because you got tired of it or you don't want to use it anymore, the effects are reversible just by discontinuing the wear, as simple as that. So how does it work? How does orthography work in this specific case with the Euclid Emerald design? These lenses are what we call reverse geometry gas permeable lenses. What they do is they gently reshape the cornea. There are some hydraulic forces that they cause a reduction of myopia up to 5 diopters with 1.5 diopters of astigmatism or cylinder. We usually analyze the results through the patient symptoms, visual testing, and comparative analysis of before and after with topographical maps. In order to start doing ortho-K, you don't really need a topographer. Of course, if you do have it, it will be a lot easier, a lot better. I'll say not easier, I will say it will be faster, because if you don't have to maybe send the patient to do a topography at any other place, of course, you will be actually seeing your patient a lot faster. Remember, these hydraulic forces are the one that create positive and negative pressure. Let me get my laser pointer. Will be positive pressure in this area over here and negative pressure in these areas over here. That changes gently the shape of the cornea, and by shaping it, we'll be actually reducing the refractive error, of course, in this case, myopia and astigmatism. So how does this work? As you can see, it's a simulation here. You can see how the emu, put it one more time. That we pick how it works. It gently reshapes the shape of the cornea. It will be similar to what a LASIK does, but instead of LASIK, of course, is permanent. In this case, it will be reversible, as simple as that. So how do the Euclid systems stand apart? Because there are different platforms all along the way. There's a long story of sophisticated ortho-K design. We have been doing night ortho-K for years and years and years. We have been dealing with the protocols, and now we have, with our design, we have what we call a straightforward fitting protocol. That means is, in order to start with your patient, you don't need a trial set or an inventory in order to do it. We have created a unique fitting algorithm, and the success rate with that algorithm is real high. And it is done in just a few office visits. The thing is, when we started doing ortho-K years ago, it took a lot of time for our patients to be treated with ortho-K. Now, with the accelerated ortho-K, it's a lot easier, okay? Now, with the different protocols, the unique fitting algorithm is really easy. And you'll see later on how it works. Also, you don't have to worry about the reproducibility of the designs. Now with the computers that we have and the different instruments, the reproducibility is really high. And every lens, remember, we are dealing here with microns. So you need to have a really nice device in order to provide or to gently reshape the cornea. But now with the state-of-the-art manufacturing that we have, you don't have to worry about it, okay? So let's see how easy it is to actually start fitting patients. 3 simple measurements equals high inect fit success. What we mean by that is, if you are able to provide us with these 3 simple measurements, that's all you have to do in order to start to practice ortho-K. And I know for sure that you guys are already doing these 3 different things in a timely and continuous manner with all your patients. The first thing that we need to provide us is a refraction, right? In order to determine potential for vision success. Refraction, normal refraction. I'm not talking about autorefractor, a normal refraction. Of course, just pay a little bit of time doing a really nice refraction in order to have excellent results. The other thing that we need to do after refraction, we need to acquire the manual or the simulated K readings. If you have a keratometer, you can use the actual manual Ks. If you have an autorefractor, you can use the autokeratometer. You can use the information from the instrument. Or if you have a topographer, you can usually use the simulated case also. So we have refraction, we have case, and then the third measurement that we need is the horizontal visible iris diameter, okay? Because that determines the lens size. And that is important because, like most of the different designs that we work with Spectrum, we always like to work with systems that you can actually customize in order to provide the best fit for your patients. You will see there are different type of ortho-K lenses. Some of them are more simple. Some of them are more customizable to work with them. The thing is, if you want to actually provide a large base of patients with a really nice product, you need to have a little bit some time of custom parameters in order to provide that. Remember, not all eyes have the same size. So if that happens, you need different sizes in order to be able to fit properly and correctly these patients. In order to do that, we measure the HVID, or the horizontal visible iris diameter, and that is very simple to do. All you need to do is to have a small millimeter ruler, or you can actually use the some auto refractor. They provide you with the HVID, or even a topographer. But if you don't have any of those two, all you need is a millimeter rule, and with that rule, you can actually measure the HVID. If you provide all those three simple measurements, we can start doing ortho-K, as simple as that, okay? Also, if you do have a topographer, we can take baseline topography maps. And I think that the most important thing for having a topographer is to actually make you faster. Also, to assess the cornea for any ocular pathology. So if you don't have it, that's okay. But usually we will recommend to maybe send to another office or to ophthalmology to do a topography and have a baseline topography in order to make sure that that cornea is healthy and ready for uh, orthokeratology in this case, okay? Remember, it is not necessarily for the initial lens selection. All you have to give me is refraction, case, and HVID, and that's it. But in order to do the follow-ups and to see how the lens is actually dealing, or how is it working properly or not, probably a topographer will be the best and easiest way to go on. And
Dr. Davila, I'm going to stop you there. So, guys, please remember, this is really important. You don't need a fitting set. All you have to give us is case, refraction, and the patient HVID, the horizontal visual iris diameter, and we will design a lens for you. This lens, with the first lens, you're going to get an 85% success rate. So imagine, most of cases that you're going to be fitting, you only need one lens. Please remember, you don't need a fitting set that costs $3,000, $4,000. That's what usually the fitting sets for ortho-K cost in your region. So you don't need a fitting set. All you need is to give us three measurements: HVID, patient's prescription, and patient's case. And we will design a lens for that particular patient. Thank you, Dr. Davila.
Excellent. Thanks for clarifying. And if you are worried, or you still are skeptic about how this works, you can actually read the smart lens research. The smart study was done years ago, and just to give you some information or background information regarding that specific research, there was a multi-clinic study. It was done in 10 different venues all around the US, and out of those 10 different clinics, only in two out of those 10, they have experience doing ortho-K. The other 8 out of those 10, they have no experience using this type of lens. They did the study just providing, like Felipe mentioned before, case, refraction, and HVAD, and they did the studies in those different 10 clinics. At the end of the study, that study was done for 3 years. They some of the endpoints, some of the results were: number one, that it was safe for kids. That's very important, right? We want to make sure that it is safe for kids, and that's one of the conclusions that we were able to actually answer in an academic, of course, research way. And the other outcome was that, like Felipe mentioned, 85% of the time, you will get, just by providing those 3 different pieces of information, you will get the first lens will be the one that actually fits the patient. And remember, out of those 10 different clinics, 8 of them, they have no experience at all working with this design. So that's how simple it is. That's why when we talk about our nomogram, when we talk about the design, when we talk about the protocols that we have established, that is all done for you in order to be able to safely and effectively and in a simple way provide ortho-K to your patients. So there is this design is backed up by research. It's not like I create something and that there you go. It has a lot of different research. Okay, so just to continue, remember we have different corneal shapes, right? if we have different corneal shapes, sometimes we do need different diameters or different designs. In case of emerald, we have what we call the emerald regular lens, and we have the emerald toric, right? Whenever we assess a cornea, we need to verify if the astigmatism is apical or if it is limbus to limbus, right? Because there's some, it could be some difference there. And if we know that information, we can actually provide you with the most correct lens. The regular emerald lens, the algorithm, what it does is calculate with the base radius, calculates base radius and optical zone size for myopia reduction, okay? This is very important also. Like Felipe was saying, all this piece of information, but at the end of the day, we want to provide you a nice platform that can provide ortho-K for adults and also myopia control for kids, right? In order to do that, we need to have the correct optical zone size, and it could vary from an adult to a kid. You don't have to worry about it because just by providing us with the information, the company can create, with the algorithm, create the lens for you. Of course, also, we will get you the correct or the most acceptable diameter of the lens. Like I mentioned before, you can have a kid having a HPID of 10.8, and another kid having a HPID of 11.3, and within that variation, you should need different diameters. But you don't have to worry about it. As long as you provide us with the information, we can calculate it for you, as simple as that, okay? And also, we align the curves to maximize centration. The most important thing in ortho-K is centration. If you have real nice centration, you have everything is done already. You don't have to worry about it. Of course, if you're going to start doing ortho-K, as a tip, I will say start with the easy cases and then start growing more confidence, and then deal with the most difficult cases. That means is start with the -1s, and -2s, and -3s. Don't start with a -6, the first case, okay? So what is the patient selection for Euclid Emerald? Very simple. Low to moderate myopes up to -5 diopters. Astigmatism less than 1.5 diopters of cylinder, okay? E-values, if you have the E-values, you can actually look at those from 0.3 to 0.7, and the case from 40 to 46. A corneal diameter greater than 11 millimeters. Those are the regular parameters. Of course, we can actually adjust from there if you need to. But see, these are the regular parameters for Euclid Emerald, okay? Very simple. So how the thing that people ask us is because we're so used to doing ortho-K with diagnostic lenses, and like Felipe mentioned ago, they're expensive. It could cost $3,000, $4,000, $5,000 just a set. How does this design algorithm work without the need of those? Sometimes you hear that information saying, "Oh, I'm not sure." Let me just tell you, this this algorithm that we have created is so excellent that without that we can provide excellent lenses for those patients. The other thing is that, like we mentioned before, Emerald, in this case Euclid, has been designing these lenses for more than 2 decades, and we have almost more than 2 million lenses on eyes already. So we are one of the biggest company, if not the biggest company in the world, providing ortho-K lenses. So our experience, that's how we getting here with the different parameters and the different algorithm. Okay, as simple as that. You don't have to worry. Also, depending on how good you get, it could get up to a 95.5% of fixed success on the first patient. That means is once you are starting to get more patients, if you get excellent information, we can provide you with excellent things, okay? Spectacle, RX, and HBID, okay? The other thing that we have is the Emerald Toric, and the Emerald Toric is the same thing, but for toric corneas. Remember, different corneas, different designs, we can provide them for you easily without any problems, okay? The other difference will be for toric, you need to have limbus to limbus astigmatism more than 20 microns of longitudinal height difference in primary meridians. Don't worry about these things. We can actually later on with the different webinars emphasize a little bit more on this. If the lens is the center, we can actually center it with the different curves, okay? The same thing, how does it apply to Euclid toric? All the calculations will be done for you. All you have to provide us case, Rx, and of course, the refraction. And we will calculate everything else for you, okay? So if you want to enter this area, I know for sure that you will love it. Just all you have to do, the hardest thing to do in terms of ortho is to start. But don't worry, Felipe is going to give you a simple way to start whenever you're fitting patients, okay? All you have to do is get Emerald certified. As part of this webinar that we're doing, we're going to provide you the tools for doing that. If you have any other doubts, you can just also send the orders to us directly to Spectrum International, and we can actually help you throughout the whole different process. Remember, you're not alone. That's the other thing that defines Spectrum. Whenever we have our products, we have consultants that help you deal with the different products. You are not by yourself doing things. We have a strong consultant group actually really to help you, okay? Like you said, we'll not be alone. Calculating the lens, providing on-fitting process. Remember, you don't have to really calculate the lens. All you have to do is provide us with the different information, and then we'll calculate it for you. If you want to calculate it, you can do it also. Those of you that really like mathematics and calculate the lens, you can do it also. But you don't really have to do it. All you have to do is provide us with excellent information, okay? Risk-free warranty, full cancellation, no trial sets, or inventory investments. We're going to provide you with an excellent platform in an easy way that is backed up by evidence and research, and actually it works extremely well in all your patients, okay? So shape the future of vision, Euclid Emerald with Ortho-K, one of the best interventions for myopia control. This is just an introduction, and of course, maybe in the near future, we will actually giving you more and different webinars about Ortho-K. Thank you, Felipe.
Okay, Dr. Davila, thank you so much for this presentation. So doctors, please remember this technology is now available in the United States, as is now available in 90 countries around the world. When I ask the optometrist or the visual specialist in the Middle East what they're doing for myopia management, they tell me we're not doing anything. So by the year 2050, 50% of the population are going to be myopic. So please know that this technology is now available. You don't need an expensive fitting set. We will help you become an expert. So all you have to do is, and I'm going to give you my email because a lot of people have been asking me about my email, Dr. Davila. I'm going to start sharing my screen.
Sure.
So a lot of people are asking me, how can they get in touch with us? So this is my email address. This is our website that you can read more about Ortho-K lenses. And this is my personal cell phone number. So please send me a message. We can fit patients together. There was a doctor that is participating in this meeting, and he's having a problem with the lens not centering well. So doctor, please just contact me, and I will help you get that lens center, and I will help you get that patient with 20/20 vision, with no glasses, no contact lenses, and no surgery. One of the most important facts with this is that a lot of ophthalmologists think that this is something to compete with LASIK, and this is not. There are a lot of patients that are afraid of getting surgery, such as myself. There are a lot of patients that don't want to do surgery because they're not of age. They don't have the age to get the LASIK surgery, or there are patients that can't because they have very thin corneas, or they have dry eyes, or they have other problems with their eyes that prevents them to have LASIK surgery. So please understand that now you're going to be able to give your patients freedom from glasses, freedom from contact lenses during the day, and you're going to be able to do myopia management. So patients that wear ortho-K lenses, and please do some research. We had Brian Tompkins 2 weeks ago, one of the most famous guys about ortho-K and myopia management, speaking on myopia management 2 weeks ago. And he is having patients since they're 4, 5, 6 years old until they're 30, 31, 32. So there's no age limitation that you can fit patients for myopia management. So now I'm going to answer a couple questions that we have in the chat. So they're asking me, how many days does it take to the lens for the lens to be ready? So Dr. Iyad, we manufacture this lens in 24 to 48 hours. And once you tell us, please ship the lens, we will ship this lens to wherever you're located in the Middle East. So it takes us 2 days maximum to manufacture these lenses. Dr. Iyad asked me, what is the age that patients can start wearing these lenses? So again, we have doctors in the United States and doctors all over the world that have patients that are 5, 6, and 7 years old. So you can fit kids with this. I know that the limitations in the Middle East are that you can only fit patients after 10 years old. So if you have a limitation like this in your country, please let us know and we will help you with that. Then Dr. Iman, how many hours does the effect of ortho-K last? So I wore ortho-K when I was a teenager, and the effects for me, they lasted for 12, 14, 16 hours. If the patient wears the lenses every night, the effects will last for as many hours as the patient is awake. Another important factor is that if you have patients that only sleep 3 or 4 hours a day, this is not an ideal solution for them. Please remember that we need to have patients that sleep over 6 hours a day daily, okay? We continue with the presentation. I'm going to answer all the questions that you have in the chat. People are talking about regression in the future. Dr. Rami, if you stop wearing or your patients stop wearing ortho-K, they will go back to their original prescription, okay? And there's something known as the rebound effect. So if you're doing myopia management and the patient stops the treatment completely, he might have a progression on his or her myopia if they don't keep wearing the treatment. It's just like braces for the teeth. Just like when you go to your orthodontist and they give you a treatment so your teeth are straight. You have to wear that treatment every night, otherwise your teeth are going to be crooked, okay? So now I'm going to share my screen with Dr. Maria Fajor that is going to be talking about myopia management using soft lenses. So give me just 1 second and we'll start with Dr. Maria Fajor.
My name is Marielle Fajor, Professional Affairs Group Director of Mark Energy. In this webinar, I will talk about myopia management and the extended depth of focus design lens Milo. Myopia has been a current topic for a few years now, but what is the main reason for the onset of myopia? Is it genetics, or rather a set of cultural and lifestyle factors? Let's try to clarify these issues and some others. The number of myopic patients is escalating worldwide in such a way that we are already talking about myopia as an epidemic. Brian Holden's studies estimated that myopia will affect 5 billion people worldwide by 2050. That will mean a prevalence of 50% of the world's population, when currently it's about 34%. In Asia, Hong Kong, Singapore and Taiwan, already the prevalence is 50% among the young children. That means 1 out of 2 is myopic. The late Brian Holden was champion of ensuring that myopia is on the World Health agenda. High myopia is strongly linked to a higher risk like cataract and retinal detachment. The concerning reality is that 1 out of 2 people will be myopic by 2050 in our part of the world. If we look at what is nearby, the estimated prevalence value in Europe is currently about 20%, depending on the area. Also, these values will grow. They will grow to 50, 54, 56, in the next 30 years. If we speak in terms of numbers of people, the data is more shocking. In 2010, roughly 227 million people were myopic in Europe. If the trend of myopia prevalence continues as expected, we might even have 416 million myopic patients in Europe by 2050. Now that we have spoken about the prevalence and the ocular risk of myopia, let's talk a little bit more about myopia itself, which is typically defined as the eye refractive stage, in which light comes to focus in front of the retina in absence of accommodation, and meaning to see images nearby clear and far away blurred. Professor Earl Smith from the University of Houston has done some investigation about the question, how does it all work? I quote, "The eyeball grows from the start from the inside of the eye, independently from the nerve system and brain. The retina can actually tell if it's nearsighted or farsighted. The info is transmitted to the pigment epithelium, through the choroid, and finally to the sclera, where it will change the biology of the sclera. In the eyes, there will be a remodeling of intracellular matrix. Enzymes degrade the tissue, and that weakens the sclera and distends the ocular pressure getting higher. So the eye becomes long in myopia." The definition of an optical correction is a slight modification that corrects lines for the purpose of making them appear correct to the eye. The definition for a disease is a change in structure or function that continues to progress over time. It could be an optical correction, it could be a disease, or it could be a combination of these two. And we must realize that it is not just an optical condition, but a disease as well. It's about the retina that's continuing to be stretched as the eye gets bigger and bigger and becomes thinner. The eyes determines whether the myopic or hyperopic and alters the growth and to achieve an optimal refractive area. Changing the focus of the eye can change the way the eye grows. Peripheral refraction can influence the central refractive area and vice versa. When using a divergent lens, ophthalmic or contact lens, to correct the myopic refractive area, the central rays focus on the retina, but the oblique rays passing through the periphery to the lens will focus behind the retina, causing a hyperopic peripheral defocus. Visual signs affecting the periphery of the retina have a strong influence on the growth of the eye. Thanks to the latest studies, we are beginning to understand the cascade between the visual signal and the biochemical signals for eye growth. It seems that the visual sign can alter the biology of the sclera. To minimize the progression, we need the image to be formed on the retina or in front of the retina at all points, and never behind the retina to avoid triggering the cascade. Aberrations are imperfections of the eye that result in light being unable to focus on the retina effectively. There are two types: lower order aberrations, higher order aberrations. The higher order aberrations are responsible for individuals reporting complaints of glare, halos, reduction of contrast sensitivity. Why is keeping myopia low so important? Myopia increases the risk of suffering ocular complications, irrespective of the level of myopia. And all of these complications have a potential blinding effect. If you look at the schedule on the right-hand side, if you have a low level of myopia, compared to ametropes, the incidence of cataract is twice. If you go over glaucoma, and you have a power over -6 diopters, the incidence of getting glaucoma is 14 times higher than an ametrope. So here you can see that we do have to concern about the kids who have a higher myopia factor. Some factors associated with the onset of myopia are out of our control. Family history. Those with a myopic parent, with one myopic parent, has 3 times more risk developing myopia, while the ones who have 2 myopic parents has 6 times more risk to get myopia. The refractive error is also related to the age. Between 5 and 9 years old, myopia progressed during these childhood years, and the condition to progress until the stabilized at the late adolescence around the age of 27. Studies have indicated that the average refractive error at the age of 7 is close to plus 1.25 diopters. We can determine that a young child with a high hyperopia will be at risk of becoming myopic, while if the same kid is already myopic, there are risks for a high myopia. Geography is also linked. Ethnicity is a risk factor because the highest prevalence of myopia tends to occur in the east and the southeast of Asia, with much lower prevalence in the rest of the world. For example, in 2010, the prevalence of myopia on the average was 28.5% in Western Europe and 47% in East Asia. Currently, we are seeing the prevalence rates of 80 to 90% in the children and young adults in Taiwan and Singapore. Cultural lifestyle factors are fueling the onset of and progression of myopia to alarming levels. Nowadays, we spend less time outdoors, and more time engaging in activities require excessive use of near vision, such as homework and digital device use. Rose et al. Defined in 2008 in the study the amount of outdoor time and near time work in 3 types: low, less than 1.5 hours per day; moderate, between 1.5 and 2 hours per day; and high, more than 2.5 hours per day. The study indicates that when time spent outdoors is high, the risk of developing myopia diminishes. When the time performing near work is low, the risk of developing myopia also diminishes, but not as so much. In essence, the study says the increasing time we spend outdoors has a greater influence on keeping myopia low than reducing the time we spend doing near work. What is the impact of axial length? The visual system is not well developed until 3 years of age. In general, the axial length increases rapidly in the early stage of life, then slowly increases until the adulthood, and then decrease in old age. The increase of power is an average between 6 and 17 years of age. The average length for full-term infants increases from 16.8 to 23.6 mil when they become adults. 1 millimeter elongation of the axial length without other compensation is equivalent to a myopia shift of -2 or -2.5 diopters. And what about binocular vision? When measuring eyes, it's important to know how the monocular vision is of the patient. In this flowchart, you have some leads to see what device or training will be suitable for the patient. It is atropine, prisms, visual training, pulse, or contact lenses, or a combination of these. Options to manage myopic patients. It all starts with behavioral management. Nowadays, we know that changing some things about the lifestyle can be as useful in diminishing the myopia progression. Some of these rules include spending at least 90 minutes per day outdoors to prevent the onset or progression of myopia. The well-known 20-20-20 rule. Limiting near tasks after school or work to at least 2 hours per day. This is also included the leisure time, handheld devices, reading and drawing, and ensuring the balance between time spending outdoors and indoors at the weekend and increase the exposure of natural light. For us practitioners, we have a toolkit. We can work with bifocal, multifocal spectacle lenses, ortho-K lenses, pharmaceutical agents, and soft multifocal contact lenses. There are some manufacturers who designed optical glasses like Zeiss, Essilor, and Hoya. Zeiss with the Myovision Pro lenses. They have an effective zone in the bottom. Essilor, Myopic Lux, dividing the lens in two parts. Within the lower part, there will be a power addition. And the Hoya MyoSmart. Basically, they are working with DIMS, defocus incorporated multiple segments. Another option are pharmaceuticals, like atropine. And atropine is related to the non-accommodative mechanisms. The system will release dopamine, which is an inhibitory chemical mediator for the growth of the eye. The atropine has the effect on the sclera by making the sclera more rigid, so it will not elongate. Options to manage myopic patients, ortho-K. RGP ortho-K can be corrected by minus 0.75 up to minus 5 diopters during the daytime. The side effects, like infections, have not been assessed yet, but we do know that there's a demonstration of a rebound effect of the ortho-K efficiency. The first CE marked ortho-K lens is the Manicum Bloom Night and the Manicum Bloom Night Toric. The lens will correct up to minus 4 diopters of myopia, and the toric will providing additional options for correcting higher levels of the corneal and refractive astigmatism. For the soft lens option, there are two lenses who have a CE mark. It's the MySight and the Milo. Milo is an extended depth of focus lens that manipulates the higher order spherical aberrations to degrade the overall quality on the retina image behind the retina, while maintaining a good distance, medium and close vision. The global retinal image quality, the GRIC, in single vision, will encourage growth. The global retinal image in single vision lenses will induce the eye growth due to the positive defocus behind the retina. When using extended depth of focus lenses, the GRIC will blur the images behind the retina and so discourage the eye to grow. The EDOF lens is designed deliberately to manipulate the higher order aberrations to provide a good vision at all viewing distances. And at the same time, the optical design renders the global retinal image quality behind the retina poor. The degradation of the image quality behind the retina acts like a stop signal. The EDOF soft contact lens offers the patient new solutions to their visual needs that monofocal and multifocal lenses cannot offer. We can define the depth of focus as the greatest distance that a view object can be moved from its theoretical position without the blur exceeding the blurring criterion. In other words, you will have an optimal vision over a wide range of distances. In these two pictures, you can understand how we can see a regular contact lens in comparison to an extended depth of focus lens. In a single vision lens, the nearby object is sharp. In the EDOF contact lens, you can see close by, intermediate and far distance very well. The EDOF design can be described to have a non-monatomic, aperiodic, refractive power and profile across the optic zone from one side to the other side of the contact lens. The advice for wearing myopia management Milo is start when the growth of the eye is minus 0.50 diopters within a year. Wear the lenses at least 6 days a week. Wear the lens at least 8 hours a day. Wear spectacles when the lenses are cleaned or stored for the day. The 3D optical designs you see over here, you can see the difference of the patterns of the CD and dual focus lenses. They have a monatomic design. The EDOF is a non-monatomic design. Here we have two studies of the EDOF. One is from Jennifer Shah, and the other one is from the Brian Holden Vision Institute, Padmaja Sarakandu. To start with the study of Jennifer Shah. It's a study to compare the visual performance of the soft contact lenses reported to reduce the myopia progression. It's a double-blind randomized crossover trial with non-presbyope myopes wearing MySight CD Pro Clear and 2 prototypes, each for 1 week. Here we see the lens designs that is being tested. The MySight with an add of +2, Pro Clear with an add of +2, the EDOF 1 and the EDOF 2. Looking at the contrast sensitivity, the objective result was that the interaction between the lenses and the distance was significant for both high contrast vision and low contrast vision. MySight was significantly better than the prototypes 1 and 2 for binocular, high contrast and low contrast vision at 6 meters. The overall subjective outcome was the Proto 1 was rated significantly better than the Pro Clear multifocal lens, and both prototypes 1 and 2 were rated significantly better than the MySight, and this is over the clarity and the lack of ghosting and stability, driving vision, lack of halos, overall satisfaction, and ocular comfort. The average daily wear time and the average daily acceptable vision time. Participants were the prototypes 1 and 2, and they could wear them each day longer than the average of MySight. They found the vision acceptable and significantly longer wearing the lenses each day. Prototypes 1 and 2 compared to MySight. The eye strain symptoms. Lose concentration when reading or doing close work. And do you feel sleepy when reading or doing close work with these lenses? Prototype 1 and 2 had the less issues or difficulties with losing concentration, and the same for feeling sleepy. They had the best results of the test. Conclusions: Prototype 1 and 2 had better subjective visual performance in numerous variables and were better tolerated by myopes compared to the commercial soft contact lens currently suggested for slowing down myopia progression. In summary, this new contact lens design have both potential for myopia control while still maintaining a good visual acuity and a favorable subject acceptance. Patients were divided in 3 groups: a control group with a single vision silicone hydrogel, and two groups wearing silicone hydrogel central distance lenses, powered an ad of 150 and 250. The other group, children, were divided by a group 4 and 3, 3 and 4, and wearing hydrogel contact lenses with a deliberately induced higher order aberration to create a profile that reduced retinal image and the quality for points behind the retina. If we have a look at the 6-month and 12-month tables, we can see that the yellowish orange color are the lens wearers who wear the lens 6 or more than 7 days a week, and their results was better compared to the ones who had 5 or less days a week. The results, although progression was found between the two contact lens test lenses, and at 12 month, the percentage of reductions of vision compared to the control lens was by the test lenses 31, 30, 27, and 21%. And for test lens 3, 1, 4, and 2, respectively, the reduction in a change of the actual length was 43, 35, 33, and 30% compared to the control lens. Looking at the result of the high contrast vision, the test lens number 3, the yellow-orange one, is scored the best in the contrast vision. If we look at the performance of the distance, intermediate and near vision, you can see that test lens 4 was out of range in the distance, but the other two, they were up close to the control lens. And it's the same for the intermediate vision. The intermediate vision, test lens 3, is scoring the same as the control lens. For the near vision, the test lens number 3 is scoring the best out of the multifocal lenses that are presented. The result of the test of the study was that contact lenses that degrade the retinal image quality behind the retinal plane, as well as the contact lenses that impose myopic defocus across a large portion of the retina, can slow the eye down in growth. Significant slowing observed in the compliant wearers, and especially versus spectacle wear. Growing evidence that the EDOF contact lenses can successfully slow down myopia. Overall, these results support the use of the novel multifocal type contact lens that slow down the progress of myopia and can confirm previous reports that the support of contact lenses to deliver myopia control. What you can use in your practice is the myopia calculator of Brian Holden Vision Institute. It will help you to let the parents understand and see what the effect is of myopia management. The only thing you have to do is go to the website, the globalmyopiacenter.org calculator, sign yourself in, and put it on your desktop. And what you can do, you can choose if you have a Caucasian child or an Asian child. You can put in the years, the age of the child, and the current refractive error. You also can check and list the myopic management option. I chose here for a multifocal soft contact lens. And here you can see, if you do nothing from now, the age of 10 minus 1, you will end up probably around minus 2.13 diopters to minus 3.25 diopters when the kid is 17. If we start out with a myopia management lens, we can reduce the growth of the power with 49%. And the kid will have maybe only, at the highest, a -2. This will have a huge effect on the life of a kid and an understanding of the parent. Myopia management can bring you a lot of tools to help the patient. And one thing is for sure, better act than doing nothing. Using the Milo extended depth of focus soft contact lens will help you to slow down the progression of myopia.
Okay, guys. So thank you so much. I am sorry I was not able to answer the chat. I'm going to do so right now. So please understand that we were moderating this, so I couldn't see the chat. But for those who want to get certified with Milo and they want to get a diploma, please send us an email. If you want to use the calculator, as you can see, and I told you my personal story, I was -150, 175 when I was 9 years old, and now I'm a -4. If I would have done myopia management back then, I would probably remain a -2, -225 instead of -4. So please know these lenses work. I know that the studies that we show you were a little bit too much information, but I wanted to show you that these lenses work and they're proven to work. So it's not like we just created a system for myopia management. The lenses do work and they're backed up by Brian Holden Vision Institute. So for those who want to register, for those who want to get certified on myopia management, please send me an email, farrojave@spctinternational.com. You can also go into our website and see the different products that we have. The lens for myopia management is being launched in May, so that lens is not available in our website yet, but I will send you all the information via email. And also you can write down my phone number and you can send me text messages. You can call me on WhatsApp. You can send me videos. We can talk about any patients that you have. Dr. Davila, can you hear me?
Yeah, I was answering the chat. I answered almost every question in the chat. We have four more in the Q&A.
Okay.
Maybe we can proceed with those, okay?
Perfect. So Dr. Iman Sater asked us, doesn't the effect decrease progressively? What do you have to say about that, Dr. Davila?
I'm not sure about the questions. What I usually is the question about ortho-K or about myopia control with ortho-K? Because usually, let's answer both just in case. For ortho-K, you were usually, and then I can answer another question that we have in the chat. If you are using the lens for ortho-K, regular ortho-K, usually after 4 days of using the lenses, you will notice a big difference in terms of a better visual acuity. And it will usually take up to 2 weeks to have the full effect of ortho-K, okay? Then after that, you have to continue to use the lenses every night. I have a strong amount of patients that they can use them every other night and are able to see well without using the lenses every other night. That could happen also, but that's just for regular ortho-K. If you remove your lenses and you don't use it anymore, it will progressively wear off, as simple as that. For myopia control, you have to actually try to maintain everything as perfect as possible. Use those lenses every night in order to maintain the myopic defocus and then provide the myopia control effect. Or those are two different things, okay? I hope I answer both. Then sleeping position, that's a really interesting question. Does a sleeping position on your side affects the fit or the results of the fitting? The answer is yes, it may affect them, because if the lens is not with good centration, it could affect the way it reshapes the eye, okay? Usually, these patients are sleeping face up, okay? I try to find a story about it. If I find one, I can actually send it to you, okay? So live, done, okay. This is how many hours using I can sleep with the lenses. That gives you the opportunity to answer another different questions. Usually, all these lenses, if they are approved for ortho-K or myopia control for ortho-K, all these lenses are made in high decay over T materials. We know from the research, whenever we go to sleep, and then whenever we wake up next morning, by having our lenses closed, our eyes closed, we can deliver what we call physiological edema, and that is about 2.8%. Okay, and that's normal. Once you wake up, you open your eyes, and that edema, probably in the next 15, 20, half an hour, it will just wear off. If you use ortho-K lenses, it may cause just a little bit of more edema, but since you're using high decay lenses, that won't actually hurt the tissues or cause any permanent edema. As simple as that, okay? That's it. And
So
then
Dr. Neeraja Tiwari asked me, are any ophthalmologists or optometrists in the Middle East prescribing ortho-K? Dr. Neera, thank you so much for being a customer. You're one of the leader pioneers in ortho-K in the Middle East. I know that you're one of our customers. And to answer the question, there are only a few optometrists and ophthalmologists taking this technology in the Middle East. So whoever wants to enter this will be a leading pioneer in ortho-K or myopia management with soft lenses. So Dr. Neeraj, thank you so much for being our customer. I know that you place orders on a monthly basis for ortho-K, so we really want to thank you for that. Dr. Nezar Damari asks us, any mechanical complications expected after using ortho-K, like corneal staining, Dr. Davila?
Well, I wouldn't say expected, as I would say it could happen, because if you do an excellent fit, you shouldn't expect. Of course, like any other contact lenses, it could happen. But luckily, the percentage of that happening is not that high, and it could be managed. Don't worry, because later on we can do a troubleshooting webinar about ortho-K and how to deal with those unexpected things that may happen.
So doctors, please remember, this is just like if we were talking back in the 1980s about ophthalmic lenses being progressive. A lot of the optometrists did not want to take on this new technology, and they were afraid of using it. Now, a lot of you guys are using progressive ophthalmic lenses. So please know this technology has been available in the United States for many, many years. Ortho-K is a safe solution for patients. Kids can wear it. Please, please do anything that you can, either with soft lenses or with Ortho-K, but please start myopia management today. So for those who want to get certified, get a diploma, get more information, please do not hesitate to email us or to call us. Thank you so much for being here with us today. Ramadan Burak for all of you, and I hope that everybody can have a great Ramadan. Shukran for being here with us today, and I hope that maybe next week we can do another webinar. Thank you, everybody. If you have any questions, please let us know. Are there any more questions?
Thank you, guys.
To know the cost of the lenses, please email us, Dr. Fadi. We have people from Oman, Jordan, Lebanon, Saudi Arabia, and based on the import cost, the lenses have different costs associated to them. So thank you. Please email us, call us. We're here for you. Please be the pioneers of myopia management in your area. You can do something different for your patients. Dr. Davila, thank you so much for allowing us your knowledge, and thank you for sharing your expertise with us.
Thank you. Nice to be here.
Have a great night. Enjoy your Ramadan. Thank you so much. Bye-bye.